And if we talk about basic things that we would run across in the realm of first aid, let's talk about burns. So you have first, second, and third degree burns. Now, typically when you guys go out to the Burning Man, are there chemicals other than alcohol? Are there any other chemicals that are out there? Then we know that there's a potential for burns to occur, right? Oh, yeah. Aside from falling into fire,
where's Brady?
That would be a problem. So first degree burn is redness, right? We've all had sunburn. So the best way to treat a burn, by the way, specifically a first degree and a lower second degree, would be cool, clear water. Okay, that's the best way really to treat a burn. Now, here comes all the stuff that was brought down through the generations. So, you know, what did our parents, you know, say? Butter.
Vinegar.
Honey.
Butter. Yogurt.
Ice.
Yogurt. Ice.
Brady.
Butter.
Yeah, I got
Cucumbers.
I've heard of butter.
Tea bags. Toothpaste.
Mud?
Listen, what? Mud? I haven't heard of mud on a burn, but
aloe vera.
Aloe vera, right?
Tree sap.
Tree sap. Yeah, I mean, honestly, I've heard it all. Well, almost. Cold refried beans, raw eggs, vinegar.
Raw eggs?
Now, listen, I have to do some research on this raw egg thing, and I meant to call Dr. Grossman of the Grossman Burn Center seriously, because I did read an article about the raw egg and it having to do with the whites of the eggs, right? And the albumin that's in there that has to do with helping to repair the skin. So I'll have to, like an egg wash. Yeah, I'll have to read on that. So it's all these things. So first degree, redness, no break in the skin integrity, right? No blistering, because when you get to the blisters, now you've got a second degree burn. So the second degree goes down to the next layer of the skin, which is the dermal layer. So the epidermis, the top part is first. The dermal layer, second degree, you get blisters. Again, the body's trying to cool that area, so it forces fluid up to the surface of the skin. And then we look at them and go, oh, look, you know, blisters. And we say, oh, let's pop them. No, because we break the integrity of the skin and you invite the potential for infection. So second degree burn, depending upon the body surface area, that's where we start to differentiate on the severity. So, and we use what we call the rule of nines. We divide the body and we use 9 as that common denominator. So the arm, front and back would be 9%, the chest would be 18%, the back would be 18%, so, you know, typically on adults, that's how it is. On a child, it's half, okay? It's 18 front and back, but on the arm, it's only 4.5. So anyway, that's what we do. The simpler way for you to kind of guesstimate percentage of burn would be the palm of your hand, represents 1% of your body surface area. Okay? So just if you're guesstimating. Cool, clear water. Second degree burn would be a dry, sterile dressing. Now, sterile meaning, you know, sterile, wrapped that way. However, if not available, as clean as you can find. Which then talks about if you're going to use some kind of bandaging and you have to use clothing, use the victim's clothing rather than your own. Okay? Well, because you don't want to be naked by the second victim, right? And their germs, so why not use their own instead of yours? Yeah, I know you guys probably naked anyway.
Yes.
You know, I might have to rethink this. I have to be naked out there?
No. You don't have to be anything.
I might end up that way, but I won't start that way. So second degree blisters, third degree down all the way into the fat and to the nerve. And typically third degree burn is kind of a white leathery look to the skin, lifeless. look, or charring, like someone described when somebody fell into the embers, okay? And the skin hangs, right, and it just falls off. It's like melts off, right? It's disgusting.
We didn't know not to.
Well, you mean put water on it?
Yeah. He was just like, oh my God, I'm gonna burn.
Well, and again, that would be what you would do. Now, here's the reason that you don't do that with 3rd degree, or that you have to be careful, is when you lose the skin, then you also start to lose body temperature. Because the major function of the skin is to maintain body temperature. So when that skin is gone, and now you've got that exposure, not only are you losing fluid, but you are definitely, your body then temperature is going down because of the exposure issue that you have. So by adding cool water, you start to drop body temperature even lower. So, and then if you get it down too low, like 95, now you're dealing with somebody who becomes what we call hypothermic, or below normal temperature. And honestly, that could be a bigger problem than the burn itself. Right. So what do? You cover them with something dry and sterile. You maintain body temperature, then cover them with a blanket if that's appropriate. If it's 150 degrees outside, I don't expect you to put a blanket over them, okay? Because they'll become hyperthermic, and you'll blow the top of their head off because their body temperature will go up. Or they'll go and have a seizure because their body temperature is too high, but we'll talk about that, the seizure issue as well. Dry sterile, treat them for shock. And by the way, what is shock? It's inadequate perfusion. You're not perfusing, you're not circulating normally, so things start to happen. The first thing that happens is your mentation. You start to become disoriented. You get confused, kind of fuzzy, can't answer simple questions like, what's your name, what day is it, where are you, who's the president, who's the Secretary of Defense. You can really have fun with this question, right? So, simple stuff. So the treatment for that is to lay them down on their back, elevate the legs 10 to 12 inches or above the level of the heart, and maintain body temperature. So with the legs elevated, what it simply does is it forces the blood to stay up to the core. So the lung and the heart and the brain. That's where we want that concentration of blood right now. We don't care about the legs being circulated. We want to keep that person awake, and we want that circulation up here where it counts. So that's really the treatment for shock. Okay? And no ice on a burn. And the reason for that is because if it's a 2nd or 3rd degree burn and they don't have that nerve feeling in there, you could actually freeze the tissue. And also that ice decreases circulation to the area, so you're really not helping to promote the healing process. To me, burns are one of the worst, if not the worst injury, to me. They're disfiguring, you never get it, you never get the elasticity back. The treatment for burns now, it's phenomenal. I mean, what they do medically. So when you see these folks that have, you know, a lot of body surface area that are burned, one of the things that happens when I talked about that fluid coming to the surface of the skin, well, imagine that the person burns, like you said, they burn the arms. Well, there's so much fluid that is released through the interstitial space or within the arm itself, that it actually, your arm will act as a tourniquet on itself. It becomes so swollen and it gets tight, like it's going to explode. So what they do is they do what they call a fasciotomy, and they take a scalpel and they make an incision and literally open up the arm. Okay? And what that does is it helps to release that pressure. And it doesn't cut off the circulation to that area. And then, of course, they graft skin from different areas. Typically, they'll use the butt or they'll use the thigh. Okay? And those of you who are my chefs and those that like to cook, when you use like a cheese grater, that's really what it is. Terrible, terrible injury. Okay? Extremely painful. Extremely painful. And really, morphine doesn't help cut the pain. I mean, for a very significant burn, they need to get to definitive care. Anything, by the way, to the hands, the feet, and the genitalia area is considered a critical burn, regardless of the percentage. That person needs to get to a burn center and be evaluated.
Why the hands?
Because we use them for everything, yeah. And because we don't want to lose this function. So now the burn center that used to be in Sherman Oaks, the Grossman Burn Center, it moved from Sherman Oaks, which was on Van Nuys and Addison, right off the freeway, is now in West Hills at the West Hills Medical Center.
What exit is the West Hills one?
Probably the fastest way would be to take the 101 and get off at Valley Circle
Okay.
and go north. And it'll then take it out to Platt, and Platt actually turns into Sherman Way. It's at the end of the very end of Sherman Way. It's up against the mountain, can't miss it.
If you have a limited amount of water, can you capture it and reuse it?
Yeah, absolutely. Yeah, sure. So if you have a limited amount of water and you're using that to cool a burn, can you capture it and reuse it? Yes, you certainly can.
Seawater? Ocean? Salt?
Ouch. Well, actually, it doesn't hurt us as the person giving the treatment.
No.
It would be
But
very
if that's the only
painful.
water you have, if that's the only water I had, I would not withhold that from treating somebody. Yeah.
Would you let it sit in the water? Or would it
No.
float?
You would be pouring the water over it, not submerging that person in there. Right? Good question. Because what happens when you sit in the bathtub or the hot tub too long? You look like a prune. Yeah, and that's the other thing, is that you don't want to submerge like an amputated part, because that's a good analogy to talk to you about what you're asking, because it distorts the tissue. And that can lessen the chance of it being reattached. Okay, and a segue into that amputated part, keep it with the person it came from. Yeah, don't throw it out the window. Wrap it in, if it's a finger, because typically it's, it's a small, it's a digit or maybe a hand, but wrap it in something that's moist, like a towel that you've moistened with water, and then you can put that on ice. But you can't open up your igloo and just throw that finger in there or whatever, because the ice will, again, distort the tissue and can freeze it, so it lessens the chance that it can be reattached.
I heard it's the best to keep it in with the saliva of the victim, meaning in their mouth.
Are you talking about teeth?
No, if a finger is, for example,
I've never heard
detached,
that.
put it in the person whose finger it was,
now,
should keep it in their mouth
you have
until
a
they get to the
problem with
emergency.
that.
They cannot
I
speak.
have a problem with that.
They cannot speak, but besides that.
Yeah, and what happens if it becomes an airway obstruction? It could happen.
No, I mean,
Yeah.
obviously if they're together, what have you.
Yeah, I have not heard that one, but I personally, I wouldn't want to take the chance, because then I got to do maybe, obstructed airway thing. I don't want to work real hard. I just want to make sure I get them to where they need to go and take care of it, right?
Well, it's their own body cells.
Yeah.
which is-
Yeah, I don't.
Teeth, I've heard. Now, teeth, they say to put it back in the socket if it was knocked out, but again, you just have to look at what's the situation with the patient. If they're semi-conscious, they're kind of out of it, I'm not putting the tooth back in the mouth because I don't want to have to worry about watching their airway, right? They also talk about milk. If you have milk, you can put the tooth into the milk because there's a direct correlation between the consistency and the ingredients of the milk and the makeup of the tooth. Okay?
I've been told, again, we get a lot of injuries in construction. I've heard from multiple sources that for all intents and purposes, that instinct to pull the nail out of your finger and stick it in your mouth is the only worse idea would be pull the nail out and stick it in your butt. I mean, it's just an awful environment.
Well, the problem is you have a lot of germs, right? I mean, you got to think about, if you're talking about an impaled object, the only time you want to pull out an impaled object is if it is occluding the airway, or if it's preventing you from doing compressions.
But specifically, I'm talking about infection.
Yeah,
the fact that
absolutely.
it's such a nasty environment in
Oh,
there.
yeah. Yeah, yeah.
And
you
it's
don't
your
wanna put it
mouth,
in
their
your mouth
mouth,
at all.
anybody's mouth.
I mean, you'd be better off putting it in a dog's mouth, because they've always said that their saliva is more healing than ours. No, it doesn't. But the better thing to do is to, in the example with an impaled object, is to immobilize that object, to keep it from moving, and then transport that person, right? If you get something in the eye, I mean, actually, you know, square in the eye itself, you for sure don't want to pull it out or try to push it through. So how do you immobilize, you know, imagine, you have a pen? That one that doesn't work? He even took the cap off. Okay, so imagine now I got this, right? Like this. So I don't want to pull it out. How do I mobilize this thing?
A cup lid.
Yeah, a cup, right? Yeah. Preferably a styrofoam cup or a paper cup.
Yeah.
Punch the hole in the bottom of the cup first. And then wrap around it. And cover both eyes and try to leave like a little pinhole for the good eye. Because our eyes work together, not independently. And if most of us freak out when we can't see. So if we can leave a little bit of a pinhole, we know that the intention of that person is going to be to look through that hole to see what's going on, right? And they'll keep their eyes straight, which will keep this thing still. So hopefully you never see it, but you certainly can see it, right? Or if somebody fell, they fell onto something, you know. So those are the things. Remember years ago, the construction worker in Malibu fell off the scaffolding and the rebar went through? It actually went through right in the corner of his eye, and it went out, and he like missed everything. Wicked, right? But now think about it. Here he is skewered on a piece of rebar.
Great picture of him sitting on the thing holding it.
You have it?
I don't have it with me, but I've seen the picture.
Oh, really?
Him sitting on the
Yeah.
gurney,
So
holding
like-
the rebar like this.
Yeah, so like think about it, right? If it was like a full piece, right? What do you do? How do you transport that person? You gotta cut it. But then when you cut it, you have to think about, are you gonna generate heat and all the vibration, right? And all the other stuff. So, you know, we got two rescues side by side down PCH, and we kind of transport them like a spit barbecue, you know? So, but people, you know, people will think about that. They got that thing out, and they're thinking, oh, I have cutters, I'm gonna cut that thing. That's a good idea, but what happens while you're doing that, and you're potentially moving it and causing other problems.
So in a situation like that, because, you know, rebar is pounded into the ground
Yes.
2 feet, you're probably not gonna be able to pull the rebar out of the ground, so you're gonna have to pull the person off the rebar.
I got a rebar.
Not to mention the fact that when they transport the package, that collapses.
Yeah. That's just shelter to go with it. The problem with that is this. I said it earlier, the mechanism of the injury, the scene safety. So if you know, I mean, it would be pretty obvious if that person were lying next to a tent and you all know that you use rebar as a stake. The potential that they fell on that thing is pretty good. So before you do anything, any movement at all, is first check, are they breathing? Do they have a pulse, right? Because those are the most important things. Because if your answer to no for the pulse, you've got to roll the ball.
Right.
You've got to take them off the rebar, and you've got to do compressions. Because leaving them there does what? Nothing. That's it. Yeah.
If they're bleeding profusely from that, you start the bleeding first.
Yes, because if you don't, and you just do the compressions wherever that hole is, right? And you may simply have a finger in the hole. It just depends, but it has happened, especially gunshot wounds. We've actually had that. Where one medic will just put their finger right in the hole, and the other one's doing compressions, because it's the only way to stop the bleeding. Or we do what we call an occlusive dressing. but that's more for the lung issue than the actual bleeding. So, you know, you potentially have, you know, some significant injuries that can happen that are certainly very different than the day-to-day type of first aid stuff that most people see. So with that in mind, always do the scene safety and then assess the situation first, your ABCs, because if they are breathing and they have a pulse, you don't want to do anything, right, until you've gotten a good assessment as to what potentially is going on. That's the way to go. Now, obviously, if they're laying there face down and the rebar's out their back, that's significant, right?
A little bit.
And you really, really shouldn't be moving them until you lose that pulse. Because when the responders, first responders get there, they're going to handle it a different way. They're going to, you know, they're going to mastermind this thing to figure out, can we get somebody under there? Can we get bolt cutters under there? Because that really wouldn't require that you're moving the patient so much. Imagine that you're close to the surface of the ground, right? Yeah. Well, but before that, I mean, if you were able to just slide those bolt cutters under and you could cut that, that's a potential way that you might have to deal with it, but you don't know. So it's a little different for y'all because you really do have some significant differences in what you're going to see. And everyday stuff is everyday stuff. But for you at an event like that, entirely different. So what do you do then when you have someone who's a diabetic? Okay, well, you might or might not know because either they have a bracelet or a necklace or they don't. Or they're able to tell you that they're diabetic. And typically some of the things that we see, a lot of these things overlap. Disorientation. We've all had low blood sugar, and it's a sudden onset. You get a little sweaty, a little pale, you start feeling kind of woozy, kind of weak. You need sugar. That's an easy fix, right? Get something with sugar in it, get soda, get juice, get candy. Soft candy though, because you don't ever want to give somebody hard candy with the potential that they might choke. So, easy fix. However, high blood sugar, so hypoglycemia and hyperglycemia, you're not going to know that just by looking at the person. You have no way of knowing that. Unless you're going to do a finger stick and test their blood, you're not going to know. If you give them sugar, it's not going to hurt them. If they're unconscious, though, because they're in a diabetic coma, which we were talking about at the break because they were diabetic and they had alcohol and they went into this super duper sugar rush, okay? You're not going to give them anything because they're unconscious. Or certainly not in a situation where they can hold a soda or, and beer's not sugar. Honey, sugar packets, right? Just pull out the lid, put it in between the gum there. It gets absorbed into the mucous membrane, helps bring the sugar level up, and it works really well. Yep, just directly.
Just between your teeth and gum?
Yep, just take that sugar packet and just dump it.
Did you say if they're hyper and the sugar's high, and you give them more sugar,
No,
it's not going to hurt
it's
them?
not going to hurt them. But you're not going to do anything if they're unconscious anyway, because you're worried about the airway. But my point is that they say they're diabetic, and you may not be able to know whether it's high or low. So giving them sugar isn't going to hurt them. Okay? Yes?
You made an analogy earlier that you can somebody can refuse
Care.
treatment.
Uh-huh.
Diabetic seizure of a guy at work, we call the paramedics, they come, they put a IV in, they give him glucose, he's snapped out of it. I mean, it's instantaneous. Well, at that point, they want to take him to the hospital. He doesn't want to go, and they called the sheriffs and put him under arrest and took him. Because once the IV was in, he had to go.
You can still refuse care. And if that happens, and it does happen with us, what we do is they have to sign the form, releases the fire department of any liability, and we call the base hospital, and we get it on tape.
Interesting, good. Yeah, the sheriff said you're going in handcuffs or
Yeah.
you're going out.
We
in
used to
handcuffs,
do,
which
they
is
call it a 51-50 hold.
Yeah.
We used to do it a lot, but
This
they're
was
not,
94.
LAPD is not real keen on it. I mean, they'll do it if we really, really, truly think that it's in the best interest of the patient. For something like that, before we even start the IV and give them the D50, the sugar, we give them the glucose paste. So you negate all of that issue. And it's like vampire blood, Halloween. Goes right between the cheek and the gum. And you just, it's like cake icing in a thing, right? You squirt it in there, and they're like, all this blood and stuff, it's disgusting. Here, you want another? I need another shot. You give them another tube, and now they're fine. At that point, they can refuse. But you have to document. So he's describing it as part of the CERT program or as part of a disaster type course. So we talk about triage, and that's when you expect to have more than 1 or 2 patients. Okay, so we talk 5, 10, and upwards. Now you have to triage. Now you've got to figure out who you can save and who you can't. And so that's a little bit different, but just on the comment about documentation, absolutely. Make little notes. Doesn't have to be a thesis paper, right? Little notes. Patient was unconscious. When we got to them, they were breathing, they had a pulse. And anything else that you notice. Patient was cherry red in color. Patient, you know what I mean? Anything that you've noticed that's out of the normal, document it. It's good for us to have because things can change from the time you get to them to the time the first responders get to them.
And marking the time of that sort of thing would probably be a good idea.
Yeah, absolutely. Just a tiny, right, piece of paper. I got to the patient at 11:50, whatever it is, and then we'll have that to look at, and then we can kind of see the course of events that have happened. So that's a good thing. What'd you do? Walk in the car?
Yeah.
So Athena, you mentioned about a stroke, right? So how do you know if someone's having a stroke? Typically, they will all of a sudden start having a slurred speech. They're talking and it is not making any sense. Other things though that usually are combined with that slurred speech is you get a facial droop on one side or the other, weakness in the upper extremities and or both. And then what we do is we use this acronym FAST, F-A-S-T. So we look at face, so, how do they appear to us? Is there a droop? And then we have the arms. So what we do is we take their arms and hold them out in front of them, and then we tell them to hold them up as we let them go. If the person is having a stroke, that affected side, they can't hold that arm up. It's very flaccid, they have no muscle control. The other thing is the smile. So you ask them to smile and only one side of the mouth will come up. And the most critical thing again is the time. The time at which you started to notice these symptoms. Because with someone who's actually having a stroke, there's about a 4-hour window in which they have to get to definitive care where they can get a specific medication that helps to dissolve the clots and minimize the long-term effects of any deficits that they might have.
You said 4 hours?
No, absolutely no aspirin. Good question. No aspirin. Why? Because this person has a clot, typically in the head. It's in a vessel in the brain. If you give that aspirin and you allow that clot to burst, you can make it worse. Okay? So that's really what's happening. Is it's at that phase where it's in the vessel and it's occluding the circulation, which is why you're getting certain signs and symptoms. Okay? Again, you sit them down, you make them comfortable, and you get help there, and you get it there now.
Sitting or lying down?
Typically, sitting up
Okay.
is better.
Time's really important in a stroke, right?
Hugely important time. Sitting up versus lying down because you don't want to increase pressure to the brain, to the head. So obviously, lying down would increase the circulation, which could increase what we call the intracranial pressure, which is not what we want. So we keep them in a kind of a semi.
Shock is the only time when you really want to lay it down. And then
Shock is when you want to lay them down and elevate the legs. Yeah.
Is there any way for a civilian to be able to determine whether or not it's a bleeding stroke versus an occlusion stroke?
Not usually for you. I mean, it could be, so is it easy for you to differentiate between a bleeding stroke and an obstructive type? No. But an abdominal aneurysm is, you know, if it bursts, they're probably going to die right there, like John Ritter. That's what happens there. So an aneurysm is like a balloon, right? It's a vessel. It's an artery. So typically what happens is, as that pulse goes through, that vessel has weakening in the walls. So it protrudes at that area. And each time that pulse goes through, if there's any plaque in there that kind of catches it, it gets bigger and bigger and bigger and bigger. And it's not draining, it's not able to free flow. So it keeps expanding and expanding like a balloon. You blow it up there and pretty soon it's going to pop. Bone. Once it pops, unless you're on the operating table, you're in deep doo-doo. Because there's no way to stop that bleeding. I tell people this, and I will tell you this, and honestly, if you don't take anything away from this today, take this. Never, ever go to the hospital by yourself. Always, always have an advocate with you. And I say that because we're not going to go to the hospital unless we're sick. And we got to be pretty sick. And when you go there, you're not going to remember a lot of things that are told to you. You need someone there to get that information and to be able to answer questions for you. 24/7. And ask questions for you. Depends. You know, it just depends on what the scenario is. Now, if y'all don't, I know we talked about insurance, but if you don't have an advanced healthcare directive, if you don't have somebody that you've designated to be your spokesperson in the event that you can't answer questions, if you haven't done that, do it. You can download the form, get the form, and do it. And keep it in your wallet, keep it in your purse, keep it in your backpack, keep it wherever, keep it in your phone. Scan it and put it in Dropbox so you can always get it if you're technically inclined. But you have to have an advocate, okay? Because it's just scary. And I'm a professional, and I say it's scary. So take that with you and make sure that you, designate somebody on your behalf. And your wishes, whether you want resuscitation or you don't. Whether you want to be on life support or you don't. Because if you don't have anyone that can speak for you, you will be. Okay? I don't want to be no one in a pot where you guys have to come water me every so many hours. It's not a good quality of life. But it's personal, so you all have to just answer that for yourself. Yeah?
We have a mutual friend, a few of us, who has DNR tattooed over his heart.
Really?
Yeah, does that actually count for anything? If he was alone, what would you do?
It's very interesting if you say that, because I have said that to people. It's like, I don't know, man, next thing you're going to see is DNR or something, right? I don't know in the court of law how that would stand up, but I will get that answer, and I'll make sure Athena knows so she can pass it out
I
to
know
you.
the guy, and he said that legally, it's Trey, right?
Yeah.
Yeah, Trey, he's told me that legally, like he looked into it when he had that done.
Uh-huh.
Legally, it doesn't
Yeah.
really hold water.
Yeah, because it does require a doctor's signature at the bottom of the
Yeah, that
form.
could be his initial.
Get your doctor to sign.
But they said that it is something to be aware of, like when they do it.
Yeah, it's kind of it's an interesting thing though, really, right? I mean, because somebody's going to figure out how to shrink that form down
Sure.
and tattoo it like,
PDF.
Prison Break, remember Prison Break, the show? And he had the whole schematic of the prison tattooed on his body. What? Oh yeah, that'll be soon, I'm sure.
What would you do?
So you can just lay down over the market scanner and find out who this person really is. Yeah, I think there'll be chip minerals pretty soon.
What would you do as an EMT?
Oh, I can't. I wouldn't be able to. No, I wouldn't because it has to have that signature. You know, I think initially, knowing me, I'd bare the chest and go, "No kidding," and take out my iPhone and take a quick snapshot, and then go ahead and instruct my partner to do compression so I didn't waste any time and take the picture. Yeah. Oh yeah, we do Facebook, Twitter. Yeah.
It'll be all over that emergency app
Yeah, I
that
know.
you came up with.
Yeah, I got ripped a little bit in the break. There's an app that I help to develop, I guess is the right word, for certain people, and anyone can use. It's a fire safety app, and it talks about fire chemistry and electrical hazards and hazardous materials and the fire triangle, the different classes of fire, and you guys can download it on your phone. And it's iPhone, Android.
What is it called?
It's called CERT Fire Safety. So again, if we talk about, let's talk about heat emergencies, right? Heat emergencies where we have the hyperthermia, where our body temperature then gets about 102 and above. You potentially could see somebody that could have a seizure as a result of that, because the temperature is so hot that the body starts to react to that and it kind of shorts out, for lack of a better term. So get them out of the environment, try to cool them down with cool towels over their head, behind their neck, and in the core areas of the body. So under the armpits and the groin area, okay, where, you know, typically when we get cold, what do? We go like this. Yeah, we go like this, we do Al Bundy. Why? Because it's warm and near the core. And typically when we get cold, what gets cold first?
Extremities.
Your extremities. Because the vessels constrict, and it causes and forces the blood to stay here in the core areas, which is why it feels warmer. Okay? When we talk about hyperthermia, where that body temperature is rising, we've got to get them out of that environment into something cool or shade, start to cool the body down gradually. And don't give them, like, don't hand them a bottle of water, ice water, because you know that they'll down this really, really quick, right? And you don't ever, remember the thing is when a body is somewhat stressed for whatever reason, you don't want to cause any other outside potential problems like airway issue, choking, or anything like that. They need it, but you have to give it to them in small increments. Okay. Speaking of which.
Heat stroke's a big thing out there.
Yeah, heat stroke's huge out there, right? No question. So, again, cooling them off. Now, if you were to take a hose, which you probably don't have, and you just turn it on, that's not good because you don't want to lower that temperature drastically that quickly. You want to do it real gradual and let the body catch up with what's happening. If they lose consciousness, what do? You get them into the cool environment. You start to do some cooling measures, so get some wet towels and things and cover them to help cool that, bring that body temperature down. And the head is huge, right? That's a really, really important area to cool down. We lose a lot of heat out of the top of our head, and it can help to distribute that cooling effect quicker. So do that, and then monitor. If they're unconscious, you monitor the airway, the breathing, and the circulation, and continue those cooling measures. If you have ice, you can put ice in a towel, okay, and put it into those core areas like the armpits and the groin area. But remember, it's not the kind of thing where, you know, do it and then just walk away. I mean, you really literally have to sit there and monitor that person. Okay, but they need they would need to get to definitive care. And one of the ways that we can help to further cool is by the IV liquid. If we have a way to cool it down, and probably out there, I don't know, I've not been there, but I would guess that they might keep those things in a cooler because it's so damn hot. Because what happens if you have somebody who's already hypothermic, now you hook up the IV and that's really hot? So that's another big consideration. Okay? There's not a lot you can do other than get them out of the environment and then start to cool them down. What I would prefer to do is, put towels in that cold water, wring it out, and put it on the body.
So you cover more surface area.
A lot more.
So the capillaries are
A lot
doing
more.
more of the work than.
Yeah, I mean, look at a beach towel, right?
Sure.
That would pretty much cover me. King size beach towel.
Sure.
Yeah, so, but I'll research it. And again, see, this is what's good, because you guys deal with things different, and you're out there for like a week or something? Or more.
Month.
So in other words, if you're coherent enough to remember that it ended, you'll leave and Yeah, is there a rule of thumb for how quickly you should cool someone down? Not necessarily. It's what we call passive cooling. And the first thing is I'd say to take their clothes off, but that's probably already done. So now, right, but if the person has clothes, take the clothing off. Because the ambient temperature is also helping to cool the body down, right? They're probably already they're in the beginning stages of shock.
Okay, they passed out, and then we picked them up, they came
Absolutely.
to, and then they put them in.
Right, because the body, you guys, this is, again, the body's trying to do stuff for us on its own. Here's the deal. Have any of you ever hyperventilated?
Yeah.
Okay, and have you hyperventilated to the point where you passed out?
Yeah.
Age 12 to 14.
So why does that happen? Because your body sends a signal to your brain that says, hey, stupid, you're breathing too fast. So the only thing you can do to rectify that is you pass out. Now what happens? Well, now you go from here to here. And now all of that blood levels out throughout the body, so your circulation is different. It's just like fainting. So if any of us in here have fainted before, you get that, it gets darker and darker and darker, and that was an indication that you could have laid down and elevated your legs, but you didn't. You waited until you hit the ground and somebody obviously picked you up. Had it happen again with some knowledge, hey, you know what? Now, if I lay down and elevate my legs, I probably can avoid actually passing out. So that's why they do it. And it's to help the body so it takes some of the stress off.